Hello, my name is Sebastian Osler and I'm a student physical therapist at Bowling Green State University. Today I'm going to be doing a video-based assignment on a full neurological screen. I do not have a patient with me, but I will be going through the motions and stating any abnormalities that you would find with the tests that you would perform during a full neurological screen. So the very first thing that you would do after the patient is done taking their subjective history, you would walk them into the room and you would do a mental status test with the patient by having them state their name and their date of birth. So for me, it would be Sebastian Osler, 12/31/2000. If they are unable to do this, you could further progress it by asking them the season that it is. Next, you would be doing cranial nerve testing. So in a traditional clinical setting, you will be using scratch and sniff for cranial nerve 1, which is the sense of smell. Any abnormalities would be inability to smell with that. The next thing you would be doing is cranial nerves 2 and 3 with a light. You will be shining the light directly into their eye and you will be observing both eyes. You're looking for constriction of the pupils while doing this. If they are unable to constrict the pupil on the side that you're shining the light into, that will be indicative of a cranial nerve 2 lesion. And then if they're unable to constrict the pupil on the other side of the face, that would be indicative of a cranial nerve 3 lesion. Next, we're going to be testing for cranial nerves 3, 4, and 5 for eye movements. For this, you will be doing a double H test by having them follow a point and just looking at their eye movements while they're doing this. So any type of abnormalities would be signs of nystagmus or shaky eye movements, or if the eyes tend to drift off in other directions while following the point, or if their eyes aren't even able to follow the point in the first place. So next we're going to be doing cranial nerve 5. So this is the face and the masseter muscle. So with this, you'll be palpating the masseter. You'll have them clench down their teeth and you'll be looking for symmetrical contraction and then also ability to make that contraction. You could further progress it by doing strength, by having the patient open up their mouth by adding some resistance to the bottom of their chin. After this, we'll be doing cranial nerve 7. So this is both sensory and motor. So the very first thing that you would do is test for muscles of facial expression. So you will have them smile, elevate their eyelids, close their eyelid, or elevate their eyebrows, close their eyelids closely, and then also puff out their cheeks. So this is what it would look like. Next, to test the sensory division of it, there is 3 different divisions. There's the ophthalmic, the maxillary, and the mandibular. So the ophthalmic, you will be using a fine point for this also, and make sure that it's sanitized and clean. You will be testing the forehead for the ophthalmic, the cheek for the maxillary, and then the jaw for the mandibular. Any type of abnormalities would be inability to sense this. You would obviously test this bilaterally also, and you would have them indicate when they are pressing or when you're adding that sensation to their face with their eyes closed. Next, we're going to be doing cranial nerve 8, which is the Weber and Rhine test. So with this, you'll be using your fingertips, going close to their ears, and just rubbing your fingertips next to their ears. You would ask them if they're able to hear that. If they're able to hear both sides, then that would be that would clear it for a cranial nerve 8 lesion. If they can't hear that, you'd use a 256 tuning fork, and you will be hitting it next to their ears, testing for sound lateralization, or if they have the ability to hear it either in the center of the head, or if they hear it on both sides of their ears. Next, we'll be testing for cranial nerve 9, 10, and 12. By doing this with the same light that you used for cranial nerves 2 and 3, you'll be shining the light into their mouth, having the patient stick out their tongue, and with this you're looking for elevation of the uvula, the south palate, and no type of abnormal movements of the tongue. So the tongue should be at midline. Any type of weakness with the soft palate, it won't elevate. So after that, we're going to be testing motor sensation of the spinal nerves. So with this, you'll have the patient flex their head forward to test for C1. You will be having the patient elevate their shoulders that would be for C1 and C2, by the way. Elevate their shoulders for C3, abduct their shoulders for C4, flex their elbow for C5 and C6, extend their wrist for C6, and then you will have them extend their elbow for C7. You can also test for finger flexion, which would be C8, and then finger abduction, so having the patient just keep their hand outstretched, and you'll be just trying to push the fingers together and have them resist those movements. Next, you will be doing the lower extremity, and also for these tests, you will be testing both sides, and you'll be testing for any type of differences on each side during these tests. So for the leg, you'll be having the patient go into hip flexion. We're having them just raise their hip. That would be L1 and L2. L3 would be raising or extending the knee. L4 would be dorsiflexion, or having them bring their toes upwards towards their head. For L5, it would be great toe extension. And then for L5, S1, it would be plantar flexion. And for S1, S2, it would be plantar flexion and eversion, or having their toes go outside. After this, you'll be testing for reflexes using a reflex hammer. You'll be testing the lower motor neuron reflexes first by doing the brachial tendon. You'll be doing the triceps tendon, the patellar tendon, and then also the Achilles tendon on the back of the foot right here at the Achilles. This would be any type of extreme movements or no movement at all when you test for these would be indicative of a lower motor neuron lesion. Then for testing upper motor neuron lesions, you will be doing the Babinski test on the bottom of the toe by making an L shape on the bottom of their foot. Any abnormalities with this would be displaying of the toes or elevation of the great toe. Then you will be testing for clonus, which is basically just putting the ankle into rapid dorsiflexion, and then testing for any type of beats that are greater than 3. This would be indicative of an upper motor neuron lesion also. For the upper extremities, you could do the Hoffman test, or just flicking the fingernail and looking for any abnormalities with that. And then you can also do the wrist clonus test also for this. And abnormalities with that would indicate a upper motor neuron lesion. After this, we're going to be testing for sensation. So for this, you would be using a cotton swab. I do not have that, so I will be using a Q-tip. And you will be doing all the different sensation areas of the spinal nerves. So it would be suboccipital, or right behind the head. You will be having the patient extend their shirt out like this, and you'll be doing above the clavicle. Have the patient bring their arm up like this at the acromion. Then you will do the medial elbow, the pinky, the index, the middle finger, and the thumb. And then you will do a lateral testing also for the upper extremities. For lower extremities, you will have them in shorts and with their socks and shoes off. You will test the inguinal line, or having them bring their waistband down just an inch. Then you will do the anterior thigh. Then you will do the medial knee, the medial malleoli, or behind the medial malleoli. And then you will be doing in between the great toe and the second toe, the lateral malleoli, and then also the popliteal fossa right behind their knee. So you would test, like I said, you would test this both sides for any type of sensation deficits and for symmetries on both sides. Any abnormalities would be on inability to feel the sensation. Then you could test for coordination. With this, you could do heel to shin. You can do finger to nose, or finger to nose to PT's finger. That would be a test for coordination. And then you can also test for dysdiacokinesia by having the patients place their hands on their thighs and alternating those movements, testing for timing and ability to perform those movements at the same time in synchronization. Then you can, if you notice any type of gait or stance deficits or posture during stance, you can bring them through a couple gait tests and stance tests. So this would be the Romberg test. You could do normal walking, tandem stance walking, and then you can also have them walk on their tippy toes and their heels. So a Romberg test, you will have the patient stand with a narrow base of support or their feet together, have them cross their arms and stand with their eyes open, observing them for any type of postural swing or anterior trunk lean or posterior trunk lean or laying to the side. You will have the patient be wearing a gait belt, standing on the side of the patient, and like I said, just doing observation. You can also further progress this by having them do it with their eyes closed also. Thank you.